I'll begin my presentation. I am planning to do my dissertation on social determinants of cardiovascular health. I'm a participant of Dhulikhel study. This is me, Rashmi Maharjan, first year PhD student at Department of Epidemiology, University of Washington.
Sorry, can everybody hear? I don't know, are we using the general system or
the general system?
Okay, are folks online able to hear?
Steve, can you hear?
Raj has given a thumbs up.
Okay, great.
Yes.
Thank you.
Thank you. I'm first generation university student, non-white, Asian, cisgender female. I belong to the same ethnicity that I will be collecting my data on. And I worked in the same institution for over a decade, and I have experience of working in cardiometabolic health for over. This is my outline for today. I think this will be really redundant, but as we all know, CVD has a great burden on globally as well as in Nepal. Almost 152.88 deaths occur per 100,000 population in Nepal. And among them, hypertension is one of the major risk factor. Almost 4.7 million people in Nepal have hypertension, but just 0.2 have controlled hypertension. And I'm just skimming the background specific to my specific aims. So as we all know, the lifestyle factors we need medicines and everything for controlling hypertension. But nowadays, there is a concept that social determinants of health, conditions and environment where people are born, where we live, learn, work, play, worship, play a significant role in development of cardiovascular disease risk factors, as well as CVD, morbidity and mortality. So this association has not been explored in Nepalese population yet. And also we know social support is a key determinant of hypertension control. Its role in Nepalese population is not thoroughly examined yet. And again, we know different people have different perception of social support. So the perception of the social support and how they feel, is it facilitating their management or it's hindering their management, it is also not known yet. So I have three specific aims. First is to estimate 10-year CVD risk and its relationship with social determinants of health, SDOH, among cohort of Dhulikhel study. To determine association between social support and medication adherence among hypertensive patients of DHS, Dhulikhel study, and to explore perceived social support among people with hypertension and its role within the treatment process. For my aim one, the study setting would be, sorry for the typo, Dhulikhel study. This is a longitudinal prospective cohort study initiated on November 2013, and the details can be found elsewhere. This would be a cross-sectional analysis of data from the second wave follow-up of DHS. The data collection is still going on. Until first week of June, we have almost 950 participants. For specific aim, my inclusion criteria would be all adult residents of 18 years and above of Dhulikhel municipality, population living at least 6 months in the municipality, and who voluntarily provide informed consent and who do not have an established coronary heart disease yet. I will exclude those individuals who are staying just for their study purpose or for short-term work. The individuals who are mentally challenged or who cannot communicate with us, and individuals who refuse to participate in the study, pregnant women will also be excluded. This is a recent concept of social determinants of health. It has 5 major components: education, access and quality, healthcare access and quality, neighborhood and built environment, social and community context, economic stability. We are planning to develop a composite score with potential proxies from these different determinants. For example, maybe highest level of education and annual income participants have, social support they have, and how long it takes for them to reach their nearest health center. And higher score would indicate that they have better healthcare access or they have equitable health. And I would use this WHO ISH chart for determining the 10-year risk, and we would dichotomize it as less than 10 or more than 10. I'm using this non-laboratory based chart because of resource constraint, and also literatures have shown that these also have almost equal sensitivity and specificity in LMICs. So I would be using R for my statistical analysis. I would summarize descriptive ones and present mean or SDs or interquartile range. And I'm planning to use multivariable logistic regression for this aim. For my aim two, the subset would be Dhulikhel heart study, a subset of Dhulikhel heart study, and I will include those patients who are under medication for at least 6 months from the date of data collection. This is not complete for potential data for my study. I assume there is association between social support and medication adherence. A priori, we are also thinking health insurance might be an effect modifier, and we'll also adjust for lifestyle behaviors, including physical activity, tobacco use, alcohol use, BMI, and fruits and vegetables copies. For exposure, we would use a MOS social support survey, 19-item questionnaire with 5-point Likert scale. And for covariates, these are reference that I would be using, maybe having health insurance, having more than 600 MET per minutes per week or more, no tobacco use, no alcohol use, and having more than 5 servings of fruit and vegetable per day, and having normal body mass index would be reference for covariates. And for outcome, we would use Hill Bone medication adherence scale. Again, I would be using same R software for statistical analysis, and for this, as my outcome is continuous variable, I might use multivariable multiplication. So this is very preliminary stage of my proposal presentation. So I'm still working on how can I calculate power or sample size for this. But I hope with the cohort of large number, it would be enough for me to depict the MDPI. And also I'm working on how can I elaborate the statistical analysis for different methods. We are assuming there might be a measurement bias because, as I say, these are proxies of components. We don't have the actual components. So we might be measuring, and most of these scales, though they have good psychometric properties, they are not developed in Nepal. So, and also, this is a cross-sectional study, so we are not able to determine the causal inference. For my aim 3, my research question is, how do patients with hypertension perceive role of social support in management of their condition? I will be using thematic analysis from Virginia Brown and Victoria Clark. I would conduct pervasive sampling, ensuring diverse participation of different races and gender. I would include adult citizen who is more than 18 years of old, who lives in Nepal and is willing to participate voluntarily, who's diagnosed with essential hypertension for at least 6 months prior to day of data collection, not diagnosed with any cognitive impairment, and who can communicate verbally in Nepali or English. After IRB participation and written consent, I'd be conducting interviews and focus group discussion. This would be a private setting at Dhulikhel Hospital, OPD of Dhulikhel Hospital, each interview lasting almost 45 to 60 minutes, using semi-structured questionnaires with probes. We will audio record all interviews and FGDs, transcribe them in Nepali, and translate to English, and we will secure all data in digital formats in password protected drive. These are a few examples of questions. I would be using thematic analysis for data analysis using maybe Max UDA. These are the steps of thematic analysis. To ensure rigor and trustworthiness, we will be using defined inclusion criteria, data saturation, data triangulation, member checking, and participants' feedback. We would also mention researchers' originality. We'll do reflexive journaling, interview memos, and this would be a multi-researcher team. We will do peer debriefing and also try to calculate inter-rater aggregation. This is my proposed timeline. So maybe in the first quarter of 2024, I will be finalizing my proposal and trying to set dissertation committee in second quarter, apply for the IRB approval in the third. Then data collection, data analysis, and cleaning will continue throughout third quarter of 2025. I hope by the end of 2025, I will be able to write a few papers and prepare my dissertation. These are few potential implications. Maybe we could inform policymakers about the non-medical drivers of CVD risk prevention, and maybe we could get some information. How can we integrate the essential component of social support in the prevention and management of hypertension? These are my references and bibliography. So I would like to thank you, Professor Annette, Carrie, Dr. Arshna, Viraj, and